Hi, I'm Dr. Randy Martin. I'm a clinical professor of cardiovascular surgery here at Mount Sinai, and I'm happy and thrilled to be joined by a gentleman that I respect and many of you know well, Ani Anyanu. And Ani is the professor and vice chair of the Department of Cardiovascular Service. Many of you have attended courses, heard him speak, and actually referred patients to him. He's also the surgical director of the heart transplant and mechanical circulatory support. So Ani unfortunately does a lot of his surgery after the sun goes down for all that. So Ani, you were going to, I think it's fascinating that you're going to talk a little bit about CTEPH, chronic thromboembolic pulmonary hypertension. This, I think, personally, as I've learned more about it, I think it's an underdiagnosed syndrome. Tell me your thoughts.
Yeah, it's one of those conditions that doctors know exist, but for various reasons we don't really talk about it much, and we don't do much about it.
Right.
Chronic thromboembolic pulmonary hypertension is a condition that occurs after pulmonary embolism. So some patients get an embolus in the lung, and for some reason it doesn't go away with the anticoagulation with the blood thinners. So in those patients, it becomes more of a chronic process where it starts to cause obstruction to the blood flow to the lungs. And it occurs in somewhere around between 1% to 5% of patients who have pulmonary embolus.
Okay.
And for how common pulmonary embolism is, we should be seeing this quite often, but we don't.
Because it's probably not being diagnosed.
Correct. It's probably because it's not being diagnosed. So there's somewhere around 5,000 cases diagnosed a year in the country.
Okay.
But that's likely the tip of the iceberg. And there are many patients who have various clinical syndromes, like, for example, feeling short of breath, and who are labeled with other diagnoses who may actually have CTEPH.
That's what I was going to say. The symptoms that they usually present with is shortness of breath on exertion, dyspnea on exertion, fatigue, things like that, are often labeled other things. I think you're going to show us an interesting case. And I'm sure that I probably didn't think about it with some patients that I saw early on. So the risk factors are the risk factors for pulmonary emboli, is that?
Yes, by and large. So it's the risk factors for pulmonary emboli. So it would be often things like inflammatory conditions, malignancies, cancers, recent surgery. It's more common, pulmonary embolism tends to be more common in females, especially during pregnancy. So, but a lot of patients do not have any risk factors at all.
Interesting. So when should our viewers and the physicians or even patients suspect this, think about it?
So I think basically if you have symptoms of shortness of breath and you've ever in the past had a pulmonary embolism or what we call a deep vein thrombosis, a blood clot in the leg, then you should ask your doctor, could this be CTEPH?
Okay, that's really important. You've got an interesting case. Let's talk about it, because I was going to ask you about the workup and then how you approach these patients. So tell me a little bit about this case.
So this is a patient we took care of recently. So he's a 60-year-old male patient.
Okay.
So he had a gallbladder removed about over 10 years ago, and as a complication of that surgery had a pulmonary embolus. So he was treated with warfarin, with the anticoagulant,
Right.
which he took for just 6 months, which probably 15 years ago was the recommendation at the time. And then he stopped taking the anticoagulation, and then fast forward to 2022, he has another pulmonary embolus. And then now he started on abixaban, which is another type of anticoagulation, which he was then told you need to take that the rest of your life. A year later, he started noticing progressive symptoms of mainly feeling tired, feeling short of breath, which initially he didn't think much about. Then he started getting leg swelling. And then he undergoes a series of investigations, and he was found to have pulmonary hypertension, which means that the blood pressure in the lungs were high. And then he was referred to our multidisciplinary team here for evaluation.
So sounds classic in a lot of ways, but I'm thinking if he changed physicians in those two or 3 years in there, if he says I've got shortness of breath and fatigue, they're going to be thinking down different paths. They might, eventually get there. Show me what does the workup for these patients entail? What do you like to do?
Well, usually the patients, because they're thought to have, or we don't know what they have, essentially. And if a patient is fatigued and short of breath, you think...
And peripheral edema.
Peripheral edema, you think heart.
You're thinking of heart.
You think the heart. So often the patients will get a series of tests that are just helping the doctors to figure out what's going on, not that they have CTEPH in mind.
Right, yeah, right.
So, and an echocardiogram was one of the first tests he had, and it has these classic signs of a right ventricle.
Ventricular enlargement,
which is enlarged and dysfunctional, and the septum pushing to the left.
Right. And
that's very suspicious of overload, pressure or volume overload of the right ventricle. And often the echocardiographers can often measure the pulmonary artery pressure. In this case, they couldn't because there wasn't much regurgitation at the time of this particular study, but he has in the past had regurgitation. And they were able to measure the pulmonary artery pressure and give an estimate, and they estimated it to be about 70.
70?
Yeah. So then he now went on to have a cardiac catheterization, which is, so any patient who is suspected of having pulmonary hypertension, the way it's diagnosed is with a cardiac catheterization, which means the doctors are putting a catheter into the heart, into the lungs, and directly measuring the pressure in the lungs. Right. And they measured his pressure, and they found he actually had pulmonary hypertension. So those numbers there show a high pulmonary.
So, and Ani, so he's got pulmonary hypertension. The VQ scan is really important in these patients?
Yeah, VQ scan is important. The other useful thing to do anytime they have a catheterization is to do a blood gas analysis, which is helpful to work the cardiac output, the amount of blood the heart is pumping. And his blood gas showed that at rest he actually had hypoxia, which means his oxygen levels in the blood were low, which goes, again with CTEPH, because if the blood isn't getting to the lungs will not do the job of exchanging oxygen. So he did have this, what we call a VQ scan, a ventilation perfusion scan, which basically is a way of examining the lung to see if all the areas of the lung are getting air and if they're getting blood.
Okay.
So in a patient who is not getting air into the lungs, then you think of conditions with the lung itself, with the lung, what we call the parenchyma of the lung. Right. So things like common things that you hear like asthma, COPD, pneumonia, those stop air from going in the lungs. Okay. But if on the other hand you have a picture like this is what this picture shows, so you have on the left an image that shows all areas of the lung are getting air, but on the right you see some areas that are not getting blood. Then that means you have some kind of problem with perfusion of the lung. And because it's regional means some areas are getting blood and others are not. In a patient with pulmonary hypertension, that's almost diagnostic of CTEPH.
So the next step is to see where the unresolved thrombi are in the pulmonary arteries?
That's correct. So, and to do that, you need some form of angiography. And angiography just means taking a picture of a blood vessel. The first test we do is a CT angiogram, which I'm not showing here. So with a CT angiogram, you can then see pictures of the entire vasculature, which is the arteries of the lung. And this is a direct angiogram where the doctors have actually put a catheter into the lung, put some dye, and took pictures of the blood vessels. And these blood vessels, for the specialists who do the study and who examine these tests, they could tell very easily this is a case of CTEPH, because all the branch arteries, as they come out of the main arteries, are pruned, and they're very small and shriveled at where they're coming out of the arteries, and that's because of chronic disease. So this test here is diagnostic of CTEPH.
And some filling defects and things. I mean, where it's just not filling in uniformly.
Yes, just not
so
filling
that would make
uniformly.
You think.
Yes.
So you've established a pretty solid diagnosis on somebody who's 60 and needs intervention.
Yeah.
So what's the choice? Because surgical removal of this is really important.
Yes, so once you've established a patient has CTEPH, the treatment is surgery, is the treatment. And the surgery is called a pulmonary thromboendarterectomy, which is shown in the
PTE, it's in the second bottom
bottom, yeah.
from the left, yeah.
Yes, where the surgeon opens the pulmonary artery and removes all this scar tissue, because often the clot has gone away, but what's happened is the body has healed those areas where there was clot and replaced it with thickening of the inner wall of the blood vessel and scar tissue.
And this is done, the surgery is done by a cardiovascular surgeon like yourself, somebody who's experienced in doing this, because it is an open chest procedure.
It's an open chest procedure, and we have to stop the heart because the heart pumps blood to the lungs, and we can't see inside the blood arteries if there's blood there.
Right.
And the way to do this operation is we actually have to put them on the heart-lung machine, cool the patient down so the patient is very cold, and then stop blood going through the body totally. It's what we call circulatory arrest. And while there's no blood going into the body, we drain all the blood out of the body, and then we can see inside these blood vessels in the lungs. The whole operation to do this often takes somewhere between 6 to 8 hours.
Does it really?
Yes, yes.
Okay.
They'll be on the heart-lung machine for at least probably 3-4 hours.
Okay.
Yes.
Okay.
Because to get the patient that cold, we have to put them on the heart-lung machine and cool the blood, which takes about an hour and a half to do. And then it takes half an hour to do each side of circulatory arrest. And then in between those half hour, we have to get some blood flowing through the brain to keep the brain and the body alive. And then we start again on the other side. And then we warm the patient up, which is another hour. So it's a few hours on the heart-lung machine, yes. Some patients cannot have surgery because the risk of surgery might be too high, or the patients might decline surgery. So if we have a patient who, for whatever reason, they're not candidates for surgery, then to palliate them, which means just to make them feel better, the interventional radiologists can put in special balloon catheters into some of the arteries and blow it open to try and increase some blood flow to the lungs. It can sometimes bring relief to patients, but it's not a recommended first-line treatment. And then the other thing that we would often do for such patients is there are drugs that we can give that help to reduce the blood pressure in the lungs. They help to some degree, but because they don't take away the problem, which is the blocked arteries, they're not really effective. So often it's just a bridging therapy, so just to bridge patients to get them in a better shape for them to go ahead and have surgery.
When you do the PTE, the outcomes have been pretty dramatic, not only in their improvement in symptoms and hemodynamics, but their lifespan. You showed me yesterday, I'd love it for you to show our viewers what a case on this gentleman.
Yeah, so this is just this is this same patient. So we opened up his lungs and took out all the thickened tissue that's obstructing it, and that's either lung, the right lung on the left side, and the left lung is on the right side, because it's a mirror image, and that's all. We have to take out all the lining bit by bit. It's a very long, protracted, tedious process, but it's very effective. On the right panel, those are the measurements of the blood pressure in the lungs. So his blood pressure in the lungs is almost normal immediately after surgery, and it was, very high before. You know those numbers.
Yeah,
those are good. And in terms of the patients do very well. So this patient had surgery in January, so now we're in March. He has no symptoms now. His leg swelling has gone away. He doesn't take any more Lasix. He's not short of breath. He says he can walk 15, 20 blocks as long as he wants without limitation. And the only medication he's on is apixaban, a blood thinner.
Blood thinner.
And he'll have to take that the rest of his life, because one question that's bothered doctors is, why doesn't this happen to everyone who has a pulmonary embolus?
Right.
So we said at the beginning somewhere around just 1, 2, maybe 5% of patients with pulmonary emboli get this chronic problem, and most of them are taking blood thinners, and yet they still get this problem. And there's a theory that it's to do with hypercoagulability, which means there's something in the blood that makes some patients more prone to developing blood clots. So once you have this condition, we will tell patients they have to take anticoagulation for life.
Yeah, I mean, this gentleman had recurrent PEs. In other words, he had an event and then he had it again. And I think about people I've seen and known who've had, you know, get the economy class syndrome and come in and have PEs, and then and others that get pulmonary emboli. And you think about that, you obviously can treat that, but you have to be in the back of your mind worrying about down the line they might develop CTEPH, and then so I think there needs to be some follow-up for these patients.
And I think and it's a relatively short follow-up in that most patients who get this condition will start to develop it within 6 to 12 months of the PE. So I think certainly for patients who have had a massive, a large pulmonary embolus, they should be followed for at least a year or two to confirm they don't have pulmonary hypertension, like with an echocardiogram, for example. Before it
gets to that stage.
Yeah, yes.
The interesting thing is you're obviously a super experienced cardiovascular surgeon doing heart transplants and valvular stuff, so that this is an extension of your techniques, your experience and capabilities. But you also have a colleague who's a pulmonologist, a lung doctor, who's an expert in pulmonary hypertension, so it's part of a team that really works with these patients.
Oh yeah, that's critical. This is a team-based approach. So we have two very senior experienced doctors. One is a pulmonologist, one is a cardiologist who specialize in pulmonary hypertension. So pulmonary hypertension is patients who have high blood pressure in the lungs. And this is just one of the several causes of pulmonary hypertension. There are different classes of pulmonary hypertension. This is just one of them. But you need doctors that are able to manage not just this condition, but the entire spectrum, because not everyone with pulmonary hypertension and a history of a pulmonary embolus has CTEPH.
Right.
They might still have something else. So you have to have a team, a multidisciplinary team that's well versed in the management of pulmonary hypertension, the diagnosis, and all the nuances. It's a big multidisciplinary team approach.
But I think people, as I said at the outset, it's my feeling, and reading the stuff I've read, is that people are underdiagnosed.
That's correct.
It just hasn't been recognized. It's not that people are missing it, but it just hadn't been recognized. So, Ani, great information, fabulous case, and I'm glad the gentleman's doing well. This wild-looking material you pulled out of his lungs, I mean, that is an extensive dissection to get all that out.
Yes, yeah. It's one of the operations we do as cardiovascular surgeons that needs a lot of patience. Like, you can't do it if you're impatient, because it just takes, it's tedious to
clean it all out.
Yeah.
I think it'd be wonderful if you could give us and give our audience and give me your 2 or 3 take-home messages about CTEPH.
I think the first take-home message is a general one, which is that not everybody who is short of breath has COPD.
Right.
So a lot of it's easy to label patients, especially patients who have a history of smoking, that have breathing problems, and say they have COPD and give them inhalers. I had a lady who had this operation a year ago. She was on oxygen for 2 years at home, labeled as COPD, and taking inhalers. And then somehow she ended up being admitted for heart failure in the hospital, and they did an echocardiogram and they found she had pulmonary hypertension. It led to a series of investigations. She had CTEPH, we did the surgery, and she's perfect. She doesn't take any oxygen. She was just in a clinic last week, several months later. So that's the first message I would say. And I think the second message is more for the patients and primary doctors. If you've ever had or ever been treated for a deep vein thrombosis or a pulmonary embolus, and you start to get symptoms of shortness of breath, fatigue, think whether you could have CTEPH. And if you're a patient, ask your doctor, could this be what's wrong with me? And I think the third is for cardiologists in particular. If you have a patient with pulmonary hypertension that you can't explain by simple, I wouldn't use the word simple, but straightforward cardiac conditions like heart valve disease, then consider referring to a pulmonologist or cardiologist who has interest in pulmonary hypertension for workup. of those patients.
And you and your colleagues have developed that program here, which is really a group attack on this problem, really, with specialists who are able to not only diagnose it but manage it. So that's great.
Yes.
Program growing. I mean,
yes, it is growing, and I think a lot of, because in addition to the chronic disease, the acute pulmonary embolus is the bulk of the work that we do, because that's much commoner, and we have a multidisciplinary team that reacts to it, and anytime there's a new case, we have a big team, pulmonologists, interventional radiologists, surgeons, cardiologists, and everyone chooses the best treatment for that particular patient. I think it has to always be a patient-driven, patient-specific treatment.
Super. Wilson, thank you for taking the time. I know you're in the middle of a busy clinic day, but I thank you for educating me about this, because I think it is, last time I'll say it, an underdiagnosed condition that people need to think about, physicians and the patients themselves. So thank you. I've learned a lot. And I thank you all for joining Ani and myself. I hope that you've continued to learn. It's really an important message to think the differential diagnosis in those patients who are labeled with some other cause for shortness of breath. Thanks for joining us. Come back and see us again soon. Thank you.